So I go to both an acute care hospital and a long-term care hospital. Depending on the nature of your acute care hospital, often the length of stay is short. There isn't that much resistance that occurs, but there are a number of patients who don't get better and they're too sick to go to a nursing home, but not sick enough to stay in the acute care hospital. Across America, there are a lot of long-term acute care hospitals, and these patients have heavy prior antibiotic exposure, often have multiple comorbidities. Maybe 40% will have respiratory failure, a number of them will have decubiti, many of them will be on a ventilator, 20% will have renal insufficiency, and these patients are at high risk of having a resistant gram-negative isolate when they come. They'll get it at the acute care hospital, or they could less likely pick it up at the long-term care, but it's thought that the long-term cares are reservoirs for resistant isolates. And indeed, that is in part true. The interplay and interchange between the long-term acute care and the short-term acute care hospitals is significant. Many patients are in and out of different hospitals. These are sick patients who come and in transitions of care go back and forth, leading to the potential spread of resistance, or at least having both short-term acute care as well as long-term acute care hospitals encounter these resistant gram-negative rods. Now, up to now, there have mostly been studies published as part of the randomized trials for licensure, and some areas where they have a high rate. But there aren't that many real-life experiences that go on where we see what's going on at the moment. So at our long-term acute care, our regional microbiology laboratory services 12 Southern California hospitals, and we looked at our resistant Pseudomonas, especially ceftazidime-resistant Pseudomonas aeruginosa isolates, I think about 111 of them, and we looked at our resistant Enterobacteriaceae, and we wanted to know what the activity was against these two new agents, ceftolozine tazobactam versus ceftazidime avibactam. The ceftazidime avibactam did very well against the CREs, against the carbapenem-resistant Enterobacteriaceae, and they did very well with that. We also looked at the ceftazidime-resistant Pseudomonas, which is an isolate we encounter often in the LTACs. And what we found was that 88% of our Pseudomonas, of our ceftazidime-resistant Pseudomonas, were susceptible to ceftolozine tazobactam. 72% were susceptible to ceftazidime avibactam, and there were no isolates that were susceptible to ceftazidime avibactam but were resistant to ceftolozane. So ceftolozane tazo really has a niche for Pseudomonas, while the ceftazidime avibactam is a good CRE drug.